I am going to be talking about the patient with diabetes mellitus. As dental professionals, we have to be knowledgeable about diabetes. We might be the first people to recognize early warning signs and be able to refer a patient for early diagnosis. Early diagnosis is very important because it significantly reduces complications of diabetes and improves the quality of life. In general, patients with diabetes have lowered resistance to infections. They have delayed healing. They have multiple systemic complications. They're prone to emergency situations with insulin shock or diabetic coma. Periodontitis may be increased, and they may have more symptoms of periodontitis and make diabetes more difficult to regulate. So they kind of play off of each other, the blood sugar against the periodontitis. In general, diabetes mellitus is a group of metabolic diseases characterized by hyperglycemia. The symptoms of hyperglycemia are polyuria, which is increased urine, polydipsia, which is increased thirst, weight loss, which is followed by polyphagia, which is increased eating, blurred vision, increased susceptibility to infections, and impaired growth. So in general, food is ingested, it's converted to glucose. There is a higher amount of blood glucose at that point, stimulates the pancreas, the beta cells in the pancreas, to release insulin into the bloodstream. The insulin enables the glucose to transport into the cells. So it's like the key that allows the glucose transport into cells to be used as energy. So insulin is the key that allows the glucose to be able to go into the cells and be used as energy. Blood glucose levels go down. Normal blood sugar levels are from 60 to 150. Usually we'll look closer to 80 to 120. Secretion of insulin is primarily controlled by changes in the blood glucose concentration. So the beta cells in the pancreas sense that blood glucose concentration change and they release the appropriate amount of insulin. With diabetes, there is inadequate function of the insulin releasing. Insulin is a hormone produced by the beta cells in the pancreas, and it directly or indirectly affects every organ in the body. In a patient who has a defect in insulin secretion or insulin action or both, they would be considered to have diabetes, and that can have implications of long-term damage to the organs, especially the eyes, kidneys, nerves, heart, and blood vessels. Type 1 diabetes, there is less glucose that is transported into cells. So there's more glucose that stays in the bloodstream. So they're hyperglycemic. There's a certain threshold that's reached in the blood, spills over into the urine. So they have increased sugar in their urine. They excrete more sugar in their urine, so they excrete more urine, polyuria. Water and electrolytes are lost. Fluid loss signals the brain with the thirst mechanism, so polydipsia. The cells are starving for food, so they increase their food intake, but they have a weight loss because the cells aren't able to use the glucose in the food. Without the glucose, the body metabolizes fat for energy. Ketones are produced and are found in the blood, becomes more acidic, and if there's large amounts of ketones in the blood, then they would go into a diabetic coma or ketoacidosis. And this is type 1 diabetes. This is it ends potentially with a medical emergency of metabolic acidosis leading to the diabetic coma if not treated promptly. There's too much insulin and it can't take that sugar into the cell, or not enough insulin, I should say, to be able to take the blood glucose into the cells. So an inadequate amount of insulin, or in some cases, no insulin. All of the following are clinical manifestations of hyperglycemia, except we already said that there was more urine, more thirst, more eating, so polyarthritis. So here's a picture of a healthy pancreas, insulin secreted into the bloodstream, and then glucose is able to go into the body's cells. In type 1 diabetes, the beta cells are destroyed and no insulin is produced, so there's no glucose uptake. These are the patients who are insulin dependent. Type 2 diabetes, there is periodic reduction in the insulin secretion, and the cells are able to take in some glucose, but not enough. These are your patients who would maybe be on metformin or glucagon. So the effects of increased action of the insulin are in type 2 diabetes. The insulin complications for someone with type 2 diabetes is going to be your hypoglycemia or insulin shock. Hypo is low blood sugar. Insulin is synthesized and released in the blood in proportion to the glucose in the blood. Blood glucose is increased, insulin is released for glucose to be transported into the cells. If there is a decreased action of the insulin, then it's not properly taking that glucose into the cells. So if there's complication, too low of a blood sugar could result in insulin shock, and we would give a patient juice, frosting, sugar, basically. Hyperglycemic reaction is going to be when there is too much blood sugar and no insulin to be able to take it into the cells. So high sugar in the blood. That person's going to be in diabetic coma or ketoacidosis. Hypoglycemic, you'll see that when people don't eat. They have insulin being released by the pancreas, but it's not, doesn't have anything to take into the cells. Type 1 diabetes is your juvenile dependent, your juvenile onset, your ketone, your ketone prone brittle diabetes. Those were some of the former names. Type 1 is absolute insulin deficiency due to the beta cell destruction in the pancreas. It's thought to be an autoimmune because the body is not producing insulin, and the body has kind of went against itself. I've had several friends who have younger teenagers who are very hungry, very thirsty, going to the bathroom all the time, and when they researched as to why this was happening, because that teenager was losing weight even though they were eating and drinking, they found that they had type 1 diabetes and actually had to be put on insulin, and they're insulin dependent with insulin pumps that are used to secrete the insulin when they eat and when they take glucose in. Type 2 diabetes is more common in the older population. More than 90% are 30 years or older. Type 2 is non-insulin dependent, adult onset, ketone resistant diabetes. Gestational diabetes is usually found in the 24th to 28th week in pregnancy. It's related to genetics, obesity, and hormones causing insulin resistance, usually in the beginning of the third trimester. Infants are born larger, premature births are more frequent, there are some congenital malformations. There's a higher death rate for those babies who are born to moms who have gestational diabetes. So they really test for this at the 24th to 28th week, and they try to identify the mothers who have gestational diabetes and monitor them very closely. It is said that a mother who had gestational diabetes has a higher tendency to develop type 2 diabetes later in life. There are other specific types of diabetes that are less common. We're going to usually hear about the type 1 or type 2, possibly the gestational in a pregnant patient. But there's genetic defects of the beta cells in the pancreas. There's genetic defects in how the insulin works in the body. There's diseases of the exocrine gland that is the pancreas. There's endocrinopathies, so there's tumors and that kind of thing that can happen with the pancreas that would affect the insulin secretion. Drug or chemical induced diabetes, infections can wreak havoc on the pancreas and cause insulin reduction or insulin action to be changed, and immune-mediated diabetes. About 1/3 to 1/2 of those with diabetes have not been diagnosed. Casual plasma glucose over 200 would be indicative of someone who has diabetes. Fasting greater than 126 for their blood glucose level. A lot of the times this is going to be found in routine blood tests. Complications of diabetes can be infection, peripheral neuropathy, fingers and toes don't get the sensation that they normally would. This is why somebody with diabetes could possibly have limb amputation if the diabetes had progressed enough. Neuropathy, which is renal disease, blindness, which is retinopathy, cardiovascular disease, amputation, like I said, when the peripheral neuropathy progresses enough. Larger babies, preterm babies, more chance of a premature baby and, you know, higher birth weight baby, but potentially complications at birth. It's a silent killer. The average lifespan for somebody with diabetes is reduced, and it is one of the leading causes of death. Which of the following oral manifestations is common in persons who are diabetic? Candidiasis. Diabetes would include a lack of salivary flow, which contributes to symptoms of xerostomia and opportunistic infections. In a dry mouth, candidiasis can flourish. General procedures need to be looked at when a patient has diabetes. For sure, scaling, root planing, and regular recall appointments should be monitored closely. You want to make sure that patients know the link between poor wound healing, delayed healing, and in general, just that things aren't going to be as healthy and they're going to have more complications because of the diabetes. If there's a link. If there's periodontitis, it's hard for them to control their blood glucose. But if their blood glucose is high, then their periodontal disease doesn't heal. Typically in the clinic, we want their A1C under 7. That would mean that they have fairly good control of their blood sugar. And we see lots of patients that are over 7. The clinic dentist can make the decision if it's close to that number 7, as far as for control, because like I said, if we control the periodontitis, then the blood sugar can also be better controlled. But when it's 12 and when it's 14, those are extremely high uncontrolled diabetic numbers that we need to be concerned with. We need to look at their diet and make sure that they are not taking in a lot of carbohydrates that are going to give them quick glucose. We want some longer lasting things that are going to have a lower glycemic index. We talked about that a little bit in nutrition last semester. Tobacco and alcohol habits are worse on a patient with diabetics. We want to watch the patient with longer appointments, because of them not being able to ingest any food. So if we've got particularly a type 2 diabetic and they have not eaten, we had a gentleman who was in the clinic and it was about 2:30 in the afternoon, and he came in and he was very sweaty. He just looked like he was having a health complication, and very sweaty. And when I found out that he was diabetic, I asked him when the last time that he had eaten was. And it was yesterday. He hadn't had any breakfast. He hadn't had any lunch. He hadn't had time. He had went right to work. And he needed some sugar. So I happened to have some peanut M&Ms in my pocket that I was saving for a mid-afternoon snack that I gave to him. He wasn't allergic to peanuts, no worries there, but I gave those to him, and then I went and also got him a juice so that would bump up his blood sugar. We waited. He felt much better. You know, he was really shaky and really sweating, and it made him feel a lot better to get some sugar in to go with the extra insulin in his bloodstream. Some of the medications that we use for type 1 diabetes are our insulins. You know, they're going to be injecting themselves with insulin, which is the key to take the glucose into the cell. For our type 2 diabetics, they're going to be on glipizide and metformin. Those are going to be their main medications that we would see on a medication list to stimulate insulin release and to prevent liver glycogen breakdown to glucose. It increases the tissue sensitivity to the insulin to be able to take the insulin into the cell to be used. There have been pancreas transplants, successful options for select patients. Lifelong immunosuppressive therapy, so lifelong cyclosporin, which could cause gingival enlargement. Antibiotic premedication could be needed for those patients. There we go, wrong way. Patients who have diabetes should be testing on a daily basis with a meter. They should know what their blood glucose is. We ask them what their daily blood glucose is, and we also ask them what their A1C is. A1C is accumulated glycated hemoglobin. This is hemoglobin, red blood cells with glucose attached. We want that number as a level of control over a 2 to 3 month time period. That number should be under 7. Glycated hemoglobin assay is what A1C stands for. Whenever I'm asked that, I really can't come up with that because I always know that the A1C should be under 7. The daily blood sugar should be under the 150, particularly under the 120 if they're testing that. So healthy, uncontrolled, under 126, up to even 150, 160, and then we would like it to be under 6 for very well controlled. Somebody that has diabetes and is very well controlled at that level will have no more increased healing or issues with our dental hygiene care as a normal healthy patient. If they're under more moderate control, that's great. We're still under the 7 where we want them to be, but they may have some delayed healing and they may have some of the issues of some progression of periodontal disease. Uncontrolled are going to be our patients where we're struggling to get the periodontitis under control because the blood sugar is not under control, and we're kind of trying to find the balance there. Diabetes has an effect on periodontal disease. Periodontal disease has an effect on diabetes. So we really need to keep one under control to have the other under control. If a patient has an endodontic infection, if they have dental implants, the dental implants may not integrate as well. The endodontic infection around the apex of the tooth may not heal as well in a patient with diabetes. We want to refer patients for early diagnosis. I have seen patients who have a fairly clean mouth. I mean, they have a little bit of plaque, but they've got a lot more bleeding than they should have for the little bit of plaque that they have. And when I ask them and question them about their medical history, you know, they're giving me answers that would make me think that they are very healthy. They're not giving any indication that there's any systemic disease or problem going on. And I will often, you know, through the years I've asked, you know, probably half a dozen to a dozen patients, you know, if they've been in for a physical, if they've ever been screened for diabetes or pre-diabetes. And a few of them have come back and said that, you know, they had went to their physician and, you know, thank you for advising them because they were diagnosed as pre-diabetic or they were diagnosed with diabetes. Some of them in that pre-diabetic phase have been able to control their blood sugar with diet. That's the first chance that, or that's when you're early in the diagnosis, they give you a chance. The physicians will sometimes give a chance to the patient to get the blood glucose levels under control themselves. but we definitely need to refer them for a physician consultation if we suspect that something else is going on, if there's an exaggerated response to the plaque. Recommend them to get treatment and have their glycemic index under control before we continue with the cleaning. Sometimes there's antibiotic premedication needed. So some of those higher numbers, we want it to be under 7 for their A1C to show that there's a good level of control. But for those people with 12 and with 14, their physicians may want to pre-medicate them because they're uncontrolled and they're unstable with their blood sugar level. So we're introducing bacteria to their system and they're not well controlled, and there is more of a susceptibility for them to have bacteremias introduced to the system and have other problems that happen because of this, infections that don't heal, wound areas or areas in the mouth that don't heal well. We want to watch the time of the appointments. We want to make sure it's after they've taken medication and when they've had something to eat. We don't want to keep them waiting, and we don't want to interfere with meal times. Often you need to ask, when was the last time you had something to eat? And watch and be aware that there could be a diabetic emergency. If there's a diabetic emergency, you need to recognize the change in the patient. You need to stop the dental appointment, sit the patient up, usually give them sugar, give them juice, give them icing, give them something that is quick sugar. If they don't respond or they lose consciousness, obviously we're calling EMS. Usually if you give sugar, they'll recover in just 5 or 10 minutes and you can monitor them. Most of the time you would not continue with the appointment. You would end the appointment at that point. Your patient with diabetes has gone into insulin shock. What is the first step in addressing the emergency? Give sugar. When in doubt, give sugar. Insulin shock is too low of blood sugar. So giving sugar to increase that level is the first thing you would do. Controlling dental biofilm, instrumentation, fluoride application, and the maintenance phase. It's important to consider diabetes in all of these situations. So fluoride, you want to look at a patient who you're giving the gel or the foam fluoride and they have to wait 30 minutes to eat. They may need to eat quicker than 30 minutes. So you'd want to take a look at maybe doing the varnish where they could eat right away. So that's a consideration for fluoride application. For instrumentation, you really want to make sure that you are adapting well and not causing any tissue trauma, any places that would potentially not heal well for the patient. You want to have them in a strict maintenance phase. So instead of a 6-month time frame for recare appointments, you might want to have them in a 3-month recall. Even if they're fairly straightforward as far as plaque levels and bone levels, you might want to see them more often anyways. And you really want to give them good instructions so they can keep plaque levels under control at home. Electric toothbrushes, make sure they're getting in there with proxy brushes. All of the patient education that you give is so very important in a patient with diabetes to keep that plaque level down. Uncontrolled diabetes, you can see on the lingual, let's see, that would be 8, 9, 10. The lingual of number 10, it's very red and inflamed there. Often I will see patients who are on the higher A1C level with some areas like that throughout their mouth where their plaque control is not good and their healing of the gingival tissue is not good. Diabetes insipidus, that is not to be confused with any type of our type 1 or type 2 diabetes mellitus. It's a rare disease and its cause is an antidiuretic hormone defect. They're going to have increased urine and increased thirst, but that is not related to the diabetes mellitus. regular dental exams, regular medical exams. So we need to really impress upon the patient, even though we're just the dental office, we need to impress that they need to come in for regular recares, and they need to be seeing their physician regularly to keep their diabetes under control and their blood sugar under control. They need to be tested and have that A1C number as a level of control over a 2 to 3 month time period. They will probably know when they start to feel those hypoglycemia signs, when they start to get a little shaky, and they can probably tell when their blood sugar gets low. And we want to ask good questions about their level of control and when they last ate. Practicing a healthy lifestyle is so important. And with this lecture, I always, when I'm in front of you in the classroom, I always like to take a look at our history. Because if we've got a history of diabetes in our families, then we potentially could be the next person with diabetes. So even though we're hygienists and we're health professionals, we need to be aware for ourselves the importance of practicing healthy lifestyle and going in for regular exams and knowing our status and getting regular blood tests and physicals to make sure that we are not having a higher blood glucose level and damaging organs over the years. Because you guys are young, most of the students are really young, and it could be several years before they really think they've got to be going in regularly for physical examinations. But if you have a family history, it's really important to go sooner rather than later. Reducing stress, practicing good home care, practicing healthy lifestyle, recognizing those low blood sugar signs, really important to teach our patients not only with diabetes but without, because they could be heading that way at some point in their life. All right, thanks for your attention.